like to now welcome Dr. Elaine McWhirter, a staff medical oncologist at the Juravinski Cancer Centre in Hamilton and associate professor at McMaster University. Dr. McWhirter received her Bachelor of Science, Master's of Science in Microbiology, and her medical degree, all from the University of Toronto. Her training in medical oncology continued with the completion of a fellowship in investigational new drugs at Princess Margaret Hospital. Her interests include new drug development in melanoma and gastrointestinal cancers and melanoma prevention, and she's been a longstanding member of the Melanoma Canada board and our medical advisory committee. Dr. McWhirter's professional memberships include the Melanoma Executive Committee of the National Cancer Institute and the Melanoma Disease Site Group of the Cancer Care Ontario Program in Evidence-Based Care. So thank you so much for joining us, Dr. McWhirter, and whenever you're ready, go ahead and share your presentation.
Thank you for the introduction and the opportunity to talk a bit today about systemic treatments for metastatic and something we call locally advanced or basal cell cancers and squamous cell cancers that wouldn't be amenable to procedures. These would be tumors that there may be too close to the eye or other important structures, or they're too large. Maybe they're deep to the invading the bone or important muscles. Just my disclosures. So a little bit of introduction, risk factors. I had a feeling Aaron would be doing that in some nice detail with good pictures. So we won't spend too much time on that. What I'd really like to focus on today is looking at clinical trial data for therapies for basal cell carcinoma and squamous cell carcinomas. Again, this is just squamous cell carcinoma of the skin when treatments with radiation therapy or surgery are not an option. Again, they are the most common cancers diagnosed in Canada, and I would say it's a bit frustrating actually that it is not being captured in terms of a registry, because it's hard to know the scope of an issue and how much it's affecting people if we don't have accurate numbers. And really can't say enough about the sun and sun protection in terms of these cancers. There's some other risk factors such as fair skin, if you've previously had a skin cancer, radiation, there's certain chemical exposures, some rare genetic syndromes, and the organ transplant patients who are quite heavily immunosuppressed. And we won't go into some detail there, just in terms of where we find these cancers. They're in the epidermis or the top layer of the skin. Again, basal cells, really 70 to 80% of all skin cancers. It's the most common malignancy worldwide. And the incidence of these cancers is continuing to grow. As mentioned, it is very rare that they spread to other parts of the body. But again, as specialists in this, we do occasionally see basal cell cancers that spread to other parts of the body, like the lung or the liver. Much more common that they develop in the head, face, and neck, and usually middle-aged or older adults. Most basal cell cancers have a mutation in something called the Hedgehog pathway, which leads to uncontrolled cell growth. So this is one of those pathways that when it's functioning normally, it tells a cell appropriately to start growing, and then when it's time to stop growing, and when it's time to die normally. And in this case, there's a mutation in this signaling pathway that the cell does not respond to the stop signal, and there's uncontrolled cell growth, which leads to tumors. And vismodegib is a small molecule, so it's an oral therapy. We don't actually call it a chemotherapy, it's a targeted therapy because it specifically targets this growth pathway, and it is able to block the pathway from that ongoing growth and stop the growth of tumors. Prior to the development of this drug, there were no treatments that worked in basal cell. There were no chemotherapies that worked. We didn't actually see these patients as medical oncologists because we didn't have treatments to offer. They saw surgeons, radiation doctors, palliative care doctors, because there just was not a medication for this. So some updated results from this drug. The first study was published back in the New England Journal of Medicine back in 2012. So it was a phase 2 study, meaning everyone got the treatment. So single arm, everyone was treated with the drug. There was 2 cohorts of patients. One were the much rarer group of patients with metastatic basal cell carcinoma, the other group with the locally advanced cancers. They had to have at least one tumor that was greater than a centimeter, and it happened after prior treatment with radiation, so they couldn't receive radiation again. And they, it's a fairly small study, but that's not surprising, given that these really large cancers aren't very common. And initially, they reported a response rate of 30% in the patients with metastatic basal cell carcinoma, and 43% in the patients with the locally advanced basal cell cancers. And so a bit more recently, we had an update on the results. So I'm going to keep everyone, I'm guessing you're seeing the slides. If I put my video on, it seems I can't advance the slides. Abby, can you just confirm you're seeing the slides when I have my video off?
Yeah, I can see the slides now, and I could see them when the video was off as well.
Okay, so I'm going to put my video off because I can't seem to move the slides forward when it's on. Not too sure about that, but okay. I can't move them again anyway. Okay. I know you're desperate to see the updated results. Okay. So after 39 months after the last patient was enrolled, this was the investigators assessed the response rates. Almost 50% of patients with metastatic basal cell carcinoma had a response. These were all partial responses, so they did not have all of their tumors did not go away. In the patients who had locally advanced basal cell carcinoma, so again, this is a large tumor on the skin, couldn't have radiation or surgery, the response rate was just over 60%. 20 of the patients had a complete response. There was no tumor, no evidence of tumor whatsoever, and 18 of the patients had a partial response. The overall survival for this group of patients with metastatic basal cell cancer, and again, this would be an incurable cancer, no treatment prior to this drug, was just over 33 months. And it was not captured for the locally advanced group. They lived for such a long time, they actually couldn't get an estimate of the median overall survival. Most folks were on treatment for about 13 months. In terms of how long it took before we saw a response to the treatment in the metastatic patients, 57 days, and in the locally advanced, 140. The median duration of response was about 15 months for patients with metastatic basal cell, and well over 2 years for folks who had locally advanced basal cell carcinomas. It's a little bit blurry, but a couple of things I want to point out here in terms of what happened to these patients. How many were still on treatment? Well, not a lot in either group. The vast majority of the patients had discontinued treatments in both groups. For a lot of these patients, it was because of side effects, especially in the locally advanced group. A few patients did die. Some were lost to follow-up. Sometimes it was physician decision in terms of the discontinuation, patient decision. Again, not quite the same as side effects, but perhaps just having to take the medication in an ongoing fashion, having to go in to the cancer center every few weeks and have blood work done and see their oncologist. And of course, there were patients, though, where these drugs did not work. And so overall survival, again, very good survival with patients who had locally advanced basal cell carcinoma on the skin, and less for the patients who had metastatic cancer. So we're not curing our metastatic patients, but certainly in the patients who have a complete response. We are seeing ongoing durable responses, and in some patients, their cancers are not coming back. And so what does this look like? This is a picture taken from the study. You can see here a patient with a really large advanced basal cell carcinoma on the nose. There's what's called a skip lesion. There's also basal cell on the forehead. And as we watch over time, we see at 3 months and at 6 months, and then out at a couple of years, a dramatic response. And in this patient, that was ongoing. So really, in terms of quality of life, to have a treatment for something like this, in days prior to this drug, sometimes very dramatic, face-altering surgeries were done, and noses were taken off, and parts of faces were taken off, and very large reconstructions were done. Because there was absolutely no other option. And, with that, we're really seeing a lot less of those huge, very morbid surgeries for patients. And in fact, in order for patients to be eligible to receive this medication, they do first need to have an assessment with a surgical oncologist, as well as with a radiation oncologist, who both need to make the assessment that either based on the size of the tumor, its invasion to other structures, or perhaps too near an eye, that radiation would they lose vision in the eye, or perhaps the eye would have to be removed if it was a surgical case. We need to submit letters from the 2 other specialties when we apply to Cancer Care Ontario for these drugs, confirming that this is really the only option that we have to treat these patients. And so there are certainly side effects to these medications, and the dysgeusia, the loss of taste, which you think could be potentially manageable, but when patients tell you that everything tastes like cardboard, it gets very, very difficult to eat. It gets hard to maintain your weight. And that's obviously a huge impact on quality of life. And so we do have a treatment option for patients who either have developed significant side effects, other side effects being that can be quite challenging for patients are muscle cramping, or their tumors have grown to this class of drugs called Hedgehog inhibitors. So cemiplimab is a type of immunotherapy. It's an intravenous medication, and if you watch any American TV, you've probably heard of some immunotherapy drugs like nivolumab and pembrolizumab. I know I've seen ads for those on the TV. This is a cousin to those, I would say. The other 2 drugs are called PD-1 inhibitors in terms of what target they're blocking. That's blocking a receptor on one of our immune cells. And this is a PD-L1 inhibitor. So it's actually blocking the ligand or what binds to the receptor. And what we're doing with this class of drugs is we're overstimulating, exciting the immune system so it starts to recognize these cancer cells as aliens and attack them. Because our immune system is usually out there looking for bacteria and viruses, and if it encounters one, it ramps up and attacks. And what we're doing with these drugs is we're getting the immune system really excited to recognize that the cancer cells do not belong, and so that they get attacked. And again, when we look at, patients who a decade ago would have had no treatment options at all, this is patients who either progressed on the Hedgehog inhibitor or couldn't tolerate it because of the significant side effects. And we're seeing an excellent overall response rate. This is in the group of locally advanced basal cell carcinomas, including some patients having a complete response, as well as partial response and stable disease. And really all of these, when we look at all of these types of responses, though we always love to see tumors shrink, we know that they grow over time. So even to put the brakes on these tumors can be very helpful in terms of quality of life for our patients. And the duration of response in the responding patients, again, we're seeing some really significant results, estimating the median progression-free survival of over 19 months. and 12-month event-free probability of well over 50%, 56.5% of patients. So really a really dramatic response that has a very clinical, significantly meaningful results to patients responding on these therapies. And, in terms of side effects, they're certainly manageable. I'm not going to get into details of side effects with immunotherapy, what can come up in the chat, but, these drugs in the skin cancer fields, immunotherapy drugs have been around for over a decade, and we're pretty comfortable with monitoring for immunotherapy side effects and treating them. We were talking about progression-free survival in the prior slide. This is looking at the overall survivals not reached. So that hasn't, these patients are doing so well, again, with the locally advanced tumors. And the estimated probability of survival at 12 months is 92%. I mean, that is really pretty incredible. I mean, for patients who have not metastatic, but locally advanced disease, unfortunately, as these tumors continue to grow, patients become at significant risk of infection and infections that just can't be treated. And unfortunately, that is a significant cause of death for patients when we are unable to get control of these tumors. The really important thing to also notice for these patients is that health-related quality of life was significantly improved as well. Over 60 or almost 60% of patients, their symptoms, even with some side effects, they reported their symptom burden as being low, other than some fatigue. And their functional status was maintained, meaning really that they were living their lives. They were doing the things that they wanted to do. So we're going to move on now to cutaneous squamous cell cancers. Squamous cell cancers can arise in other parts of the body. And again, we've talked about that it's very common to see these on the head and neck area. I'm going to distinguish this from a group of patients who have squamous cell carcinomas that develop in the throat and the tonsils. Though they are being used with some similar treatments, they are, in general terms, their treatment approaches are different than we would for squamous cell cancers that are on the skin. Again, we won't spend a lot of time on the introduction. Second most common non-melanoma skin cancer, accounting for about 20%. It is also on the rise. We have had treatment that we've offered our patients with cutaneous squamous cell cancers in terms of chemotherapy, and I'll do a little bit of a historical review on that. We know that in these cancers, tumor suppressor genes are frequently mutated, and there's something called the UV signature. So it's been identified that these are mutations that are related to UV exposure and, of course, again, sunlight, tanning beds, and that these tumors have a high mutational burden, and that is likely related to the DNA damage from long-term sun exposure. I guess the only positive there is that tumors that have a high mutational burden, meaning that they have a lot of mutations, actually respond better to immunotherapy. There's if you will, a lot more abnormal targets for the immune system to get triggered by and realize that there's something wrong. So really the largest retrospective study of patients with either locally advanced squamous cell cancers or metastatic was from Cowie in 2021. So this is really a retrospective observational study. These patients weren't randomized to receive chemotherapy, looking at patients treated between 2008 and 2015. So 82 patients who received chemotherapy as their first type of therapy. Majority were male. Again, we tend to see this in an elderly population. 88% ECOG1, meaning that patients were functionally quite well. They were up and about and living normal lives. And again, majority of them had prior radiation that had been intended to cure that tumor on the skin, but they had recurred. So a couple of types of, so a chemotherapy combination rather, with two drugs, carboplatin and a Taxol. And then about a quarter of them had cetuximab, which is an antibody to a different type of receptor, a growth receptor, but not part of the immune system. And only a quarter of these patients went on to receive any additional types of other chemotherapy regimens that were perhaps borrowed out of the other types of squamous cell carcinomas. And so when we look at how long patients were on therapy, pretty dismally short, 4 months for the locally advanced patients, a couple of months for metastatic. Response rates quite low. Again, we were talking about numbers in the 30, 40 plus percent when we looked at immunotherapy there, and 60% in the targeted therapy with Hedgehog inhibitors for the basal cells. And survivals, again, much lower, even when we look at locally advanced, much lower than some of the numbers that we saw with basal cell with some of the newer drugs. And so fortunately, we have immunotherapy for squamous cell cancers. Again, this is a follow-up study at 43 months. Initially, this was published in 2018. And so it's a bit of a busy slide. So I'm going to draw your attention to the response rates. So the column on the left is the initial results from 2018. And the column on the right is the updated results in 2021 at the European Association of Dermato-Oncology. So high response rates, almost 50%. The disease control rate, again, that combination of completely shrinking tumors, partially shrinking tumors, or having tumors that had stopped growing, very high, about almost 3/4 of patients. And that durable disease control rate, 63%, a little bit of a loss down to 60% over time. And durable meaning these were patients whose responses had persisted for at least 100 days. I think what's really impressive here, and certainly we see this in the clinic, is that over time, the number of patients who go on to have a complete response increases. And so from 2018, just under 4% of patients had a complete response, and that goes up to just over 17% of patients at the update a few years later, with the median progression-free survival not being reached initially, but out at over a year and a half. And the patients thus far have been followed for an average at the time of this update for 15.7 months. I think this was a really important breakdown to see, because again, more cancers as folks get older, and that there was no loss of response. So as patients got older, arguably it looks like maybe it got better in our older patients. So about 43% for patients under 65, 53% response rate in the 65 to under 75 age group, and about 45% in the patients over 75 years old. And again, there are some side effects with immunotherapy. This is given intravenously every 3 weeks, but from a quality of life perspective for responses to these tumors, most patients are feeling quite well, and we're able to manage those side effects. The estimated survival at 2 years for these patients, about 47%. Estimated probability of overall survival at 2 years was just over 73%, and the median overall survival has not yet been reached. We have another immunotherapy that's been studied in squamous cell cancer, so pembrolizumab, which is a drug that was first shown to be effective in melanoma. This is again for patients with recurrent or metastatic cutaneous squamous cell cancer, and there was no role for surgery or radiation. 105 patients, most of them male, most of them had prior treatment. And again, this drug's being given intravenously every 3 weeks. Disease control rate, as we saw previously, similar to the cemiplimab, over 50%, so 52.4% of patients. And what does that look like? So this is, so we can see on the left panel, very extensive squamous cell carcinoma of the scalp at 6 weeks and at week 35. So I mean, really dramatic results. And as you can imagine, how much this impacts quality of life. These can be painful for patients. They need to require a lot of dressings, risks of infection, be quite difficult for patients when they've got to this stage. It's hard to tell on the left panel, but this is sort of just under the jaw, this patient's neck at baseline. And then when we see it at week 6 and at week 35, really completely cleared up. So pretty dramatic response. So key takeaways for patients with non-melanoma cancers, such as advanced basal cell and advanced cutaneous squamous cell cancer, we have very effective therapies, 2 lines of therapy for the basal cells, the Hedgehog inhibitors, as well as immunotherapy. And for patients with squamous cell cancers, immunotherapy. And, we do sometimes turn to chemotherapy as well for patients who've progressed, or in folks sometimes where we can't use immunotherapy because, for example, we know this is a risk in patients who have transplants. There is a risk of losing a transplant with immunotherapy, and we do wind up using chemotherapy instead. Again, I'm always happy to have an opportunity to talk about sun safety. Remember to reapply your sunscreen every 2 to 3 hours, less than that in water, wide brim hat and sunglasses. We're going to be out and about during the day, but if there's something you'd like to do in particular, whether it's tennis or golf, something that's for hours, try and do them earlier in the morning or later in the day. An alternative, or maybe in addition to sunscreen, in areas where you can wear SPF clothing like shirts and pants, then you have less sunscreen to apply. And certainly look at an investment in swim shirts to wear in the water. Shade is better than nothing, but shade alone is really insufficient, especially if that is a cabana that's on the beach. You get a fair amount of reflection from the water and the sand nearby that I've certainly seen patients sunburned who tell me they spent their time entirely in the shade. And of course, don't forget about your winter sunscreen. Those skiers are getting sunburned, not windburned. Though the overhead UV index is low in winter, you're getting the reflection from the snow. And there's also the altitude if you're skiing, which is a higher rate. And thank you for your time and listening.
Thank you so much, Dr. McWhirter, for that great presentation. And thank you so much for joining us this evening. We really, really appreciate it.